I think it's okay, Rochelle, to
Yeah,
begin.
yeah. Okay. Welcome, everyone. Thank you for being here today on our March webinar series on global perspectives on medicine, rehabilitation, and robotics. We have two fantastic speakers today who are going to be speaking to us about revolutionizing recovery, the power of collaborative innovation with wearable technology. Our first speaker is Dr. Robert Scheidt. He earned his BS in electrical engineering from Marquette University and MS and PhD degrees in biomedical engineering from Northwestern University. He served as a systems engineer at Baxter Healthcare and as senior research scientist at Medical Research Labs Incorporated. In 2000, Dr. Scheidt founded the Neuromotor Control Laboratory at Marquette University and the Medical College of Wisconsin. This lab uses robotic tools, simple virtual reality systems, and wearable technologies to probe how the human nervous system uses sensory information to optimize movements and interactions with the physical environment. Dr. Scheitz recently served a 4-year term with the National Science Foundation as a program director for the Mind, Machine, and Motor Nexus program, the Future of Work, and the Human Technology Frontier program, and the Foundational Research in Robotics program. Welcome, Dr. Chait. Our second speaker is Kimberly Bassendale. Kimberly Bassendale is a postdoctoral fellow at Northwestern University and the assistant director of the Neuromotor Control Laboratory at Marquette University and the Medical College of Wisconsin. She's also an active clinician with experience in inpatient and outpatient neurological rehabilitation. She earned a BS in kinesiology and a doctorate of physical therapy from the University of Wisconsin-Milwaukee. She is most passionate about improving mobility and community integration amongst individuals affected by neurological disorders. Her work with Dr. Scheidt has explored the usability and feasibility of wearable technology to promote upper limb use in subacute stroke survivors in the inpatient rehabilitation setting. So I'm going to turn it over to both of you, and thank you so much for this talk today.
Yes, and thank you both, Rochelle and Michelle, for inviting us to be here today. And we're excited to be part of this community and surprised that it's already halfway through March already. A little bit in denial on that. It came up quick. All right, so we can go ahead and get started. First and foremost, Bob and I, we don't have anything to disclose for this presentation. And for today's presentation, I'll start us off. I'll talk a little bit about the user-centered design process that we used as the foundation for developing our wearable technology for stroke survivors. And then I'll provide some more specific examples of how we quantified user experience with technology that helped to inform further iterations and device development. And then we'll switch over and Bob will take over and discuss some of the future directions of wearable devices in the field of rehab. And we'll also talk about some logistical and practical insights that we've gained over the years for use of wearable technology in research and rehabilitation. So first, I did want to begin with some background for some motivation behind our work. And this is a statistic that can be a little bit defeating, but every 3 seconds, someone somewhere in the world has a stroke, which has really profound incidence, a high rate that affects many people. The good news is we're getting better at treating stroke, so our risk of mortality is going down, but that does mean that we have a growing population that's living with the aftermath of stroke. And so stroke can affect people in a number of ways. It can lead to deficits in motor function, sensory function, cognition, speech, or a combination of all of those factors. And really, it's unsurprising then that stroke is a leading cause of disability in the United States. So we really do need some innovative ideas and technologies to help meet the needs of this patient population, especially as there's concern for resources being limited. So an important goal for stroke rehab is to improve functional movement by encouraging what we consider a virtuous cycle of use-dependent relearning. It's kind of, quite simply, it's the idea of if you don't use it, you lose it. So we want to get stroke survivors to have successful experiences moving their more affected arm after stroke to really gain some motor function and improvements. There's a number of ways that this cycle can be broken, especially for stroke survivors, right off the bat, maybe someone's not even deciding to use their more affected arm, and that could be because of issues with neglect, where they just already aren't really paying attention to their more affected side. And then very commonly too, people might be really motivated to use their more affected side after stroke, but when they try to use it, they don't maybe have the most success with it. It could be physically they're not able to accomplish a task with their more affected arm, or that they try to, but it's too demanding from a time point, like it takes too much time to complete, or it's too cognitively demanding. And that might lead someone to be less likely to use that arm. And that can lead into kind of a detrimental cycle that we call learned non-use, where they get in a habit of not using their more involved arm, leading to worsening function and use of that more affected side. And so really we want to intervene as early as we can. In stroke, it's really important that we act quickly. The greatest potential for neuroplastic recovery is going to be in the early weeks and months post-stroke. So the driving hypothesis for our wearable technology is to use technology to motivate survivors to use their more affected arm in this early window after recovery, when they have the greatest potential for neuroplastic recovery, hopefully improve their sensory motor function and their overall quality of life. So before I dive into our wearable technology, I do want to take a step back and talk about how we got here. Since its conception, our system has gone through a number of iterations, and we've really relied on the user-centered design process to drive those iterations. I'll go back. The very first part of the user-centered design process is to specify the context of use. In our case, we're working with stroke survivors, so we needed to understand what setting the users are going to be using this device in. Are they using it at home versus an inpatient rehab facility? That can change how the system functions. We also want to know maybe how much help they're going to have to use it from caregivers, from clinicians. And there's a lot that goes into understanding this context of use, and there's a lot of literature search that you can do at this stage, but also just asking the user, what their environment looks like, get to know kind of their context really well. The next step is to then specify user requirements. And here I think it's important to really align the goals of our team as kind of the developer with the goals of the user. And if we design something on paper that we think addresses the problem really nicely, but we risk losing the interest of the user if they feel like our goals aren't matching their goals. And the fun part then usually is with our engineers. We get to design really great solutions to meet those user requirements. And again, this is really important to have a team process where multiple perspectives are definitely going to be better than just one perspective. And then finally, the last step is to evaluate that design against the user requirements. We get to assess if our technology actually met our original goals. We get to see what the user's perspectives were, if they felt that we met their requirements and their needs. And with that information, we definitely want to go back, because we can gain a lot of insight from that evaluation, that maybe we missed something in the context of use, or we learned about maybe another user requirement that we hadn't thought of. And that's where we go back to redesigning and re-implementing different solutions. But also very important too is that we don't stop there. We go back and we reevaluate and see, with those changes, even if sometimes we think they're pretty small, they can still have a profound impact on how it shapes the user experience. And the overall goal, we hope to leave this cycle at some point and say that we designed a successful solution that fully met the user requirements. And really important to acknowledge too is that there are a lot of people involved in this cycle, in this process. First and foremost, we want to involve our users, which might seem a little obvious to say. Of course, we want to involve our users, but making sure they're at every step of this process. I think sometimes technology in a clinical setting can get a bad reputation, where you have a really fancy, cool machine that collects dust in a corner of a clinic, unfortunately. And part of that could be maybe that technology wasn't reevaluated for that specific context among a specific population that you tend to use it with. We also involved family members pretty heavily in the process as well and gained their feedback. For stroke survivors specifically, a lot of their family members could be at times caregivers for them, so it was good to get their perspective as well. And our clinicians were great resources during this process as well. They really helped us to understand the context and user requirements from a more general perspective. And for our system, we were hoping to use it for stroke survivors no matter their functional level. And so to really be able to generalize their system, our clinicians gave us really great insights. And then, of course, our engineers, we couldn't have so many of the innovative solutions that we do without our engineers to help us to get there and to design sometimes things that we don't think are possible. They figure out ways to do it, which is wonderful. And we've also involved behavioral science into our process as well. A big goal of our system is to get people to use their more affected side more. And so with that, we're asking people to change their behavior. And so having the perspective from the behavioral scientist has been helpful in different considerations for our technology. And then really briefly too, you might want to consider things like your hospital administrators or third-party payers and involving them in the system, just to make sure that you have the resources that you need to be able to carry out this process successfully. And before I move on, I do want to thank, Bob can speak to how many years it's been. I think we're going on 10 years since the kind of inception of our system, and it's gone through a number of iterations, and we wouldn't have been able to get here without all of their help. So we thank all of our past participants, students, collaborators for enduring this cycle with us. All right, to go back to our system a little bit to give it some more detail. Again, our goal was to design a wearable system that could be used with minimal clinician input, and it would remind stroke survivors to use their more affected arm at times when they were otherwise idle. And we'll be talking about use of this technology in an inpatient rehab setting. The system that we developed is called Souvenir, and it consists of these two wearable devices that pair with a custom cell phone app. And that will prompt users to perform exercises at different times of the day. The two devices that are worn on each wrist are called MetaMotion R+ devices, and they have accelerometer, gyroscope, and magnetometer capabilities. They charge really quickly and hold a pretty good charge with a micro USB. They also have vibration motors, which is what we use to program the devices to vibrate, very similar to the sensation of like a cell phone vibrating. And that was used to prompt users to perform the exercises. And another great feature of this device is it gives us Bluetooth capabilities where we can pair it with other devices. Specifically for us, we paired it with a cell phone application to communicate both ways together. And then another great feature from MetaMotion is that they have open source API and it supports it across a number of platforms. So we were able to use Android Studio, which is a free software, to develop our custom application and use this. Again, it was very easy, off the shelf. You purchase the MetaMotion device, it's ready to go, it's ready to program. And they're fairly cheap. So MetaMotion it comes from this company Ambient Lab, and they've come out with different versions of the MetaMotion devices. They remain kind of around the $100 to $150 price range per device, and usually that does come with some type of accessory like a Velcro or silicone band or clips to use as accessories for wearing the devices. These silicone bands did come from Ambient Lab. So with the help of our clinician colleagues, the actual exercises that we had people do went through a standard progression across all of our patients, no matter their functional level. So patients really started where when they were cued, we asked them to do this tap exercise, where they didn't have to move their more affected side, they simply had to draw attention to it. They'd feel the vibration, they'd touch their more affected side, and then go about their day. When they after at least doing that for one day, they could progress to the assist stage. So now they're using their less affected side to help move their more affected arm through this range of motion. And finally, if they're able to, it would just be to independently move that more affected side through its range of motion. Each day while the patient was in inpatient rehab, they wore the devices for a total of 8 hours, and their activity was monitored. For this purpose, we just looked at acceleration for the feasibility of this study. And within the 8 hours of activity monitoring, we were able to schedule 3 30-minute exercise sessions that the patient and our study personnel helped them to decide kind of in between the therapies, when would they be idle, when could we schedule these exercise sessions. And each session, the haptic cues or those vibration cues were delivered every 30 seconds for a total of 60 cues per session. We were really interested in providing a higher dosage of activity, so people were moving their more affected arm as much as we could get them to. But based off of previous feedback from our users, our goal was to really improve limb use and awareness of that limb. And so we spaced out the cues over a longer duration so that patients would keep being redirected back to their more affected side, but the task itself doesn't require their full attention for the full 30 minutes. So on the right side here is one example of what one day of time synchronized accelerations looks like, with the more affected side shown in red and the less affected arm shown in blue. And those gray bars are showing we can look at the activity for each of those 3 exercise sessions, and we can compare, or from these data, we can really assess movement response to our cue. And the overall aim of the study was to determine if Souvenir was feasible to use in an inpatient rehab setting. So I'll touch on a couple metrics from this. We were able to complete the study with 30 individuals. We did have a somewhat higher attrition rate of around 29%, and that did improve with some changes that we made to our consenting process. We had about 18% of missing data. This occurred due to both technological failures, but also it could have just been from the setting that we were in. If a patient discharged due to a medical change in status, then we considered that day as kind of a lost day or some missing data. And then we asked patients to keep their cell phone and their devices within Bluetooth range, because if they separated too far, that could also result in some missing data. And patients did a really good job of this. On average, they kept those devices within Bluetooth range 94% of the time. And so this highlights a little bit of more detail of how we processed our accelerometer data, with the top part showing the raw 3D accelerations. We then filtered it and computed the overall magnitude of the acceleration, integrated it, and were able to determine a threshold of if someone met a certain magnitude of acceleration, if that counts as an activity or not. And with that, then we looked at comparing a person's movement before a cue was delivered to after. One thing we wanted to make sure of, if we just looked at after the cue was delivered, we might miss if someone just happened to be moving before it went off, and it could kind of artificially inflate our responses. And so we wanted to see if people are truly responding to our cues, we should see a significant difference between before the cue goes off and after the cue goes off. So each of these dots represents a patient, and this is the percent of time that they're moving before the cue even went off to after the cue went off. And we want this to be as close to 100 as we can, to say, people are moving every time that cue is delivered, but showing some improvement in their movement, we saw that as a big positive. So from this graph, we're pretty confident that people are responding to our cues as we intended. And then if we look across, this graph is showing all of the cues throughout the day, starting with maybe this is the first cue. Oh, sorry, my pointer's going a little rogue. The first cue of the day, what likelihood were they moving when that cue went off? And this is across all participants. So before the cue went off, we kind of get this noisy signal where people are moving maybe around 35 to 45% of the time, but then people are much more likely to be moving after the cue. And we can see as the session progresses, maybe there's a little bit less likelihood that someone's going to be moving and responding to that cue. So that might give us a little bit of an indication from this data that people, maybe they're losing a little bit of interest, but overall they're still moving and responding to the cues across the whole cohort. And then to assess user experience, we provided a number of different surveys. If you are interested in seeing the exact surveys that we used in the wording, we did have a publication that was recently accepted and published that you can go to this article on applied science. If you search mine and Bob's name in the supplementary materials, you can access those surveys with the PDF version for free. And so the first survey that we looked at was the intrinsic motivation inventory. This is a pretty long survey. It essentially provides a prompt to the patient asking, or it'll say something like the exercises were fun to do. The patient rates 1, not at all true, to 7, very true, of how true they feel that statement is. This will ask a number of questions across these categories, and it breaks it down into the patient's perceptions of those exercises. Did they feel they had some choice in the exercises? Did they find that they were interesting? Did they feel competent while performing them? Did they feel they were putting in some amount of effort? Did they find value in the exercises and completing them? And did they feel pressure or tension while they were doing it? We want high scores for these first 5 categories. We actually do want a lower score for the pressure, because if they felt very anxious or tense while doing our exercises, they would have rated it really high, which wouldn't be a good thing. So based off of this survey, we definitely feel people responded positively to our survey, or to our exercises in our system, and they were motivated to complete those exercises. The next system that we looked at was the next survey was the system usability scale. And this is a shorter 10-item question where, again, they're prompted with a sample question or statement of, for example, I thought the system was easy to use. And then they agree or rate their agreement with that statement on a scale of 1 to 5. This survey does have an established threshold. So if your scores are above this dashed line of score of 68, then it's considered that that system is deemed usable. And we tested this in the inpatient rehab facility. I didn't mention, just for time, we did follow up with people at home to see their thoughts on using the device without the exercises, just monitoring their activity for future efficacy study purposes. And people similarly between home and inpatient settings, they found the system to be usable. And then finally, we provided the Quest, which is a 12-item survey. Again, it asks questions of how satisfied were you with, and then one of 12 items, it'll ask their satisfaction, and then they rate on a scale of 1 to 5. In home and inpatient settings, patients were satisfied with the technology. And then the final piece to the Quest, which I think is really helpful to look at, especially in terms of thinking about the development of the device and kind of what features to focus on. The Quest asks you to rate of these 12 items that the survey asked you about, which 3 are the standout most important to you? And pretty overwhelmingly, patients said that they wanted something that was easy to use. And so that gives us a lot of direction of, if we are going to change our system, we need to consider this pretty carefully. Is our changes going to change how easy the system is to use? And we can also see some differences in maybe how someone responds at home versus in an inpatient rehab setting. So patients at home, they might care more about the durability of the device or how well we're following up and communicating with them, versus an inpatient, they might care more about safety and how we're actually delivering these devices. So this part of the survey is really helpful to understand the user's perspective. So overall, we found a lot of success with this study. We found that users they enjoyed our devices. They found it usable, motivating, and satisfying to use. And we were able to successfully prompt them to use their more affected side to a greater degree. We do have a lot of more data to sort through with this study, but it does inform that maybe we want to make our system a little bit more interesting, keep people's attention, and make it fun for them so that they will respond or be more likely to respond to our cues. So with that, I will pass it over to Bob to present, and I'm going to stop sharing my screen for you, Bob.
Great, thank you, Kim. Thank you very
As
much.
I'm pulling it up, any comments, Bob? Oh,
No, thank you. That's great. So can you see my screen?
Yes,
Yep,
we
you're
can.
good.
Yes.
Great. Okay. So for the second part of the presentation, I'd like to share our recent thoughts on how it might be possible to increase the impact of our work with Souvenir by offering it on the global stage. And so I'm going to describe 3 considerations for moving forward toward that goal. So the the first set of considerations are technical in nature, and they're motivated largely in part by the feedback that we received from users of Souvenir from that inpatient study that Kim just described. And specifically, several of the users wanted to know how they performed when using Souvenir. They wanted feedback of their performance, either in the moment or at the end of the day. And they indicated that such feedback might increase their motivation to do their exercises. So the next part of my presentation will present our preliminary efforts to add some machine intelligence to Souvenir to provide that desired feedback in real time. So at a very high level, it's possible to think of machine intelligence applications in the context of wearable activity monitors at 3 different levels of complexity. At the first level is the kind of activity detection that was used in Kim's approach to data analysis in her study, which we based on the work of Kwako and Catherine Lang. And many movement detection algorithms of that sort are based on the application of a simple static threshold to acceleration magnitudes from the wearable inertial measurement units. And this kind of algorithm answers the question, did an activity occur? The second kind, the next level of complexity, is that of activity recognition. Now here, an algorithm analyzes the temporal flow of data for patterns that are consistent with each activity in the set of activities. When a match occurs, the algorithm applies the appropriate label to that section of the data. And this kind of algorithm answers the question, what activity occurred? The third and the most complex set of algorithms are those that not only recognize the activities, but they also compared the observed data to population-based norms to attain some meaningful measure of distance away from the nominal performance. And the goal here is to answer the question, how well was an activity performed? I am going to focus briefly about 3 aspects of our current research focus, which is on the activity recognition part. So feature engineering, it focuses on the application of our joint clinical and engineering expertise to the identification of patterns within the temporal flow of data consistent with each of the activities in our cued activity program. Algorithm development, which is what people generally think of when you talk about developing machine learning algorithms. And then I'm going to talk a little bit about deployment, which brings our efforts back into the realm of the practical application in a given use case context. So within the context of our work, feature engineering, that first aspect of the development, it's the process by where you identify characteristics of the data that will help you differentiate one activity from the next. And as I will show you shortly, we're currently focusing on time domain features, such as patterns in the acceleration magnitudes we observe in response to cues. And we're also looking at frequency and domain data, such as signal power within specific frequency bands after the cues. which particular features or combination of features that are useful, that's going to depend not only on your choice of the sensors and where you're going to place them on the body, but it also depends upon the specific activities that comprise your activity program. For example, during the tap exercise, we would expect substantial accelerations of the less affected arm sensor and a short pulse of acceleration magnitude on the more affected arm when the subject intersects, hits that arm. Here on the right-hand side, I'm showing plots of acceleration magnitude sort of stretched out in time relative to what Kim showed you as a function of time for the more affected arm on top and the less affected arm on the bottom. And these are data in response to a single cue response. I've aligned the data so that time 0 is the onset of the 1 second fibrotactile cue. And as expected, we observed substantial accelerations on the less affected arm and a short pulse of acceleration on the more affected arm. During the assist exercise, we would expect substantial accelerations on both arm sensors. And that's what we see in this particular cue response. And during the independent exercise, one would expect to see substantial accelerations on just the more affected arm sensor, as seen in this example response. So just by looking at these data, one might expect that the total acceleration signal power in each of these two sensors within that 5-second window following a cue, well, that could be a really useful characteristic for recognizing each of the 3 cued activities in our program. So now let's look at the algorithm development. There are many different ways to build intelligence into a wearable technology. For our implementation, we used a machine learning software package, an open source tool called TensorFlow. And within TensorFlow, we created a multi-layer perceptron with 2 hidden layers and 320 trainable parameters. And that may sound like a lot, but in the world of algorithm development, that's actually a pretty small model. We trained the model on a subset of our human labeled data, and we tested model performance on a separate subset of that data. And I want to, we actually settled in on 6 features of the data that we thought were important. And we have 5 output labels. So the 3 labels of our activities, and we augmented that with 2 additional labels. A no response label, because sometimes people just don't do what you expect them to do. And then we also had a response type unknown. So when the human labelers were looking at the data, if it was really unclear what the heck they were doing, we put that, we assigned that cue response to the unknown response category. So we have 6 features as an input, 5 output labels, and 2 hidden layers with 15 and 10 units each. So despite the model's small size, it really performed pretty well, almost 80% accuracy. And so here on the right-hand side, I'm showing what's known as a confusion matrix. And this is where we can see how well the model's predictions, shown here along the bottom of the grid, well, how well these predictions match up to the human assigned labels that I'm showing here on the right. And ideally, the boxes along the diagonal should be very dark, and all of the cue examples that we used in the evaluation, they should line up here along the diagonal. And the off diagonal boxes should be basically empty in the ideal case. The model's worst performance was down here in the unknown category. And these are the these are the cues that the humans also struggled to categorize. So overall, when we take into account all of the performance far exceeded chance level of performance, which was an accuracy of 20% for this 5-class problem. And as such, this little model could very well suffice for the purpose of providing real-time feedback of which exercise the user performed in response to any given cue. Now, there's many, many other different kinds of algorithms that one could use. And another popular data-driven approach is something called k-means clustering. And so we also evaluated k-means clustering. And for k-means clustering, you plot the data within your feature space and you try to identify separable clouds within the data points. And this type of approach works really, really well when the data self-organize into these nice globular clusters. And our data did not do that, sadly. So instead of a nice diagonal confusion matrix, the best we could do with k-means clustering was something like this, where we attained classifications that made an absolute mess out of our confusion matrix with an overall classification accuracy of 18%, and which is really chance level performance for our 5-category classification task. So k-means is out. In one last example algorithm, we examined the performance of a random forest implementation in our 5-category classification problem. So in the random forest algorithm, we construct a cascade of decision trees that make independent class-based decisions based on the input features, and or if we stack these things in layers, it can also be based on prior decisions of lower level trees. And so on the right-hand side, I'm showing you what our model, the best model that we could get, what our model structure looked like. And this is kind of unintelligible to mere mortals. But this, so it had 16 levels of decision trees, and overall there were 121 estimators. This is the best structure that our training and validation could identify. And we got about the same performance as with our multi-layer perception. So after training the random forest on one subset of the data, and we tested it, the model predictions on another subset of the data, we obtained an accuracy of 78%, so just 1% better than the multi-layer perceptron. And again, we see this really nicely diagonal matrix that again the algorithm struggled with the unknown classification. The random forest model, as we just saw, it's really considerably more complex than the multi-layer perceptron. And so the best random forest with its 16 levels of decisions, put that in contrast to the 3 levels of decisions in our multi-layer perceptron. And from an implementation and deployment perspective, if we're going to include this on a low-cost Android cell phone, really the multi-layer perceptron currently holds favor as the most deployable solution that we've seen so far. Okay, now I'd like to consider some logical considerations for moving our wearable solution into the global arena, particularly as they relate to hardware and software solutions. And we're going to talk about some of the decisions that we've made along the way. So on the hardware side of things, one should consider whether to use off-the-shelf or custom technology. And they both have pros and cons. Sorry for all the words on this, but it's really very straightforward. So the benefits of off-the-shelf technology is that when you use commercially available solutions, that can really offer faster development cycles, and you can leverage existing distribution channels, manufacturing and distribution channels that you don't have to set up. However, many off-the-shelf technologies use proprietary data formats that you can't access when you're developing a system. Moreover, you as the system designer have no control over when the system you will use will stop being produced. By contrast, custom design technologies offer you complete control over your data and the product lifecycle of your technology. On the other hand, developing your own hardware comes with higher development costs, slower development cycles. It requires, very specialized knowledge, and you'll need to develop partnerships with manufacturing, distributing, marketing partners. For our project, we opted to go with the off-the-shelf hardware for the benefits that it provides. On the software sides of things, one should consider whether to develop open source solution or to retain proprietary rights to the software. Here again, both options have pros and cons. By providing our software solution as open source, the end users are empowered to reshape their solution to their own local needs and resources. It's a potentially lower cost solution. However, the end user has to have some software system skills. And as with any software components, this kind of solution will be sensitive to changes in application programming interfaces that third parties might provide. And as such, these custom solutions, they're really not suitable for medical devices strictly defined, but they can be suitable for exercise reminder systems that don't require FDA oversight or EU, TUV, or some governmental body oversight regarding safety and efficacy claims. On the other hand, proprietary software, they can provide a turnkey solution for the end user. And if it's provided by a larger company, they can leverage existing distribution channels. But these benefits come with a financial cost, and they're going to provide the end user with little control over the form and the feel of the end solution. So here again, we opted for the open source solution for the relative merits that it can provide. Finally, I'd like to bring the talk full circle and talk about some of the practical considerations of bringing a technology like Souvenir to the global stage. And from a practical perspective, we know from user experience research and from our own experience that a solution that's designed for successful use in one specific use case context, well, it might fail dramatically when it's tried to be applied in another different context. And on the global stage, there can be unforeseen challenges that include those related to differences in infrastructure and its relative reliability, resource available, both material and financial in the different settings, language differences that could impact, especially software design and the user interface. Literacy rates may differ, and that could pose a challenge to integration of your technology into the local use case setting. And when you have international partners, there can be unfamiliar cultural considerations that that could make your system make people hesitant to assume integrate your system into their environment. And so for all of those reasons, one must recognize the need to re-engage that user-centered design process. First off, by understanding the specific context of its intended use. And I want to give a shout out to recent conversations that we've had with Dr. Chidebele Ojukwu at the University of Nigeria. And we met her at Northwestern University. And our conversations are to do just that, to explore the use of our technology for use within the context of using wearables to promote aspects of women's health in Nigeria. And so I'd like to thank Chidi for her insights into the opportunities and challenges and the potential application of Souvenir in Nigeria. So with that, I would like to thank our multidisciplinary team of clinician scientists, movement scientists, behavioral scientists, and engineers, as well as our funding sources. None of our work would have been possible without their generous support. And so with that, I'd like to now open up the floor for any questions.
Thank you so much, Bob and Kimberly. That was just a fantastic presentation. And a really great example of kind of like the potential of wearables in making a difference in stroke and stroke function and exercise. And then let the idea of this affordable technology being able to then be translated and potentially impacting others in other low resource settings and developing spaces. So just wonderful presentation. there are a couple of questions in the chat, so I'm gonna field those for you. And then there's a question in the Q&A. And if anyone else has additional questions, please put that in the Q&A or in the chat, and then we will respond. So one of the first questions was about cost. So Bobby and Kimberly, you kind of brought up the fact that you deliberately chose to use something that was pretty affordable. What Olumide Dada asked about the cost. Can your product Souvenir be purchased, and at what cost? You talked about the fact that you used you customized a solution that was off the shelf. Can you share a little bit more about that? And kind of if someone wanted to try what you just did, what would their cost be?
Yeah. So thank you for the question. And there's really sort of, I think, two ways of looking at this. So we've gone with the lowest cost hardware solution that we could, that still provides us access to the data that we want and the ability to collect the data at rates that we decide, and without the filtering or proprietary data processing that other well-known solutions and more costly solutions provide. So this Ambient Lab, as Kim mentioned, it's about between 100 and 150 per wrist-worn device, which I know it's not the cheapest thing, but that is what it is. And we went with Android development because you can get Android phones, very powerful Android phones, by the way, for very cheap. And so for, under $350, $400, you could get yourself a system. And then we've decided to make our software open source so that just this sort of thing can happen. So a person would be responsible for buying their own devices and then downloading the software and then integrating it themselves. And so that's why I said that the end user has to have, or somebody associated with the end user has to have a little bit of the software skills to make this happen. But the other option, and for some of the roboticists still know about Dave Rankensmeyer, he and I had a conversation about Souvenir and the different approaches. And the other option is to form a company and to go the proprietary route where you can sell the technology. And the reason for doing that is that, especially if it's a medical device, you need to be able to pay the programmers. You need to be able to pay the folks that can generate the documentation and the testing for doing something like an FDA 510K regulatory, for managing the regulatory process. And we have really tried to avoid stepping into that space because really what we're doing, it's exercise reminders. The therapy is we want to remind people to do the therapy that their therapists are prescribing. And so we're not a medical device. We're trying to avoid that. We're trying to make our technology available at the lowest cost possible, and enabling people around the world to do the same.
Awesome. There's another question from Dr. Wamsley. She's asking, it was directed at Kim, that you projected future considerations of Souvenir in the home for function versus exercise. That question was, any consideration to do this in an inpatient rehabilitation facility and that type of setting?
Yeah, that's a wonderful question. I think another kind of, maybe this doesn't fully address the question yet, but some of the inspiration for why we chose an inpatient rehab facility was that we really wanted to get into the rehab process or recovery process early to really form these good habits. And I think some considerations for inpatient setting to home is that the user themselves, they might be a little bit more like everything's new to them when you have a stroke. You just had this new injury. You're forming your own new routine. And so we were hoping that with implementation of Souvenir in that setting, that we can get some good habit formation right away off the start. And then versus at home, people, they might be settled, they might have their routine, and you're introducing something new, the user might perceive that a little bit differently. Comparing kind of, if I understand your question correctly, to exercise versus function, and that can sort of get into what Bob had mentioned of, are you looking at movement detection or activity recognition? What capabilities do you need to be able to make some type of quantification of function versus exercise? There's a lot of great work though too. Bob had mentioned from Catherine Lang, who really looked at specific to stroke use ratio. So how often am I using my more affected side compared to my non-affected side, and using that as a specific metric. So I think depending on exactly what metric you want to look at, that can kind of change some of those considerations between home and inpatient settings as well. Hopefully that answered the question okay, or provide some clarity.
Thank you. This may be a follow-up because it kind of talked a little bit about kind of the data. And this might, either of you, Bob or Kim, could answer. The question is, how did the data look over the days of the intervention for the affected limb during non-cued period of times? Are there any perceptual options for cueing other than vibration? So it's kind of two questions, but either of you can take it or both of you can take the answer.
Yeah. That's great stuff that I would love to have included in the presentation if we had a lot more time too. So I'm glad that that question was asked. Definitely to answer the question of, are there other perceptual options? Absolutely. I think a major reason for withdrawal was that people just didn't like the vibration sensation right off the bat. So we would do a demonstration with them and they would feel the vibrations and they'd say, no, I don't want this. And so if we could offer alternatives for people where maybe instead of the vibration, we offered, like a visual cue. The device on the slot PowerPoint, I didn't mention it, but it does have LED capabilities. So you can use different colored lights to prompt activities. And that has been used in previous iterations. I think the vibration was used more so to really grab people's attention versus if you're already not focusing on your arms much, you're watching TV, sometimes maybe missing the the visual feedback. You could also use auditory cues that could come from the cell phone itself, as kind of like a ringing reminder. I think it's important to think again to the individual person of what would they like and trying to figure out what works best for them. Because I know not everybody clearly liked the vibration, but some people might find like a constant dinging to be, maybe more aggravating than the vibration. And then in terms of how the data looked during the non-cued times, that's also a great question. That's something that we're looking into further as we're kind of answering some different questions for our data. Our hope is that with the people that are being cued, that also will carry over into their non-cued time. And that hopefully by encouraging more activity, then we see more activity throughout the rest of their day. Bob has done, this was before I came in the inpatient setting. Bob did some case study work with our previous student, Jake Horter, and he actually was able to see that people were more active after they were cued, especially during certain exercises as they progressed. Maybe they were doing more of the independent exercise, and then they showed more activity later on in the day when they weren't cued. So also a great question. We're hoping to get more answers from our data, but really that's also going to require some type of efficacy comparison of people who are cued versus non-cued and what really our device is doing in terms of changing movement behavior throughout the entire day.
So
Go ahead,
sorry,
Bob.
Michelle. If you so that set of case studies that Kim just mentioned with Jake, that was published last year in JNER, and so there's some pie charts in there where you can see the possibilities of what happens in the uncued time periods. It shows great potential, but whether that really carries out in a real efficacy study. I mean, we've done now 2 feasibility studies, and we're really confident that our system is feasible to be used both in the inpatient and setting and in the unstructured home settings. So if you're
Could you drop that reference in the chat, Bob? Sorry to interrupt. Just so
you bet.
people that are here could grab that DOI. Sorry to interrupt. Were you finished?
Yep.
Okay, I wanted to, there were 2 clarifications around your experimental protocol. One question was, what level of function would the participants have be required to have in order to participate? And then the other question was around your recruiting process and how, like, did you have difficulty getting your 30 participants, and how long did that look, and how big your population were you recruiting from, just kind of logistics?
Yeah, I'd love to answer some of those questions. So from a recruitment standpoint, we were recruiting just at a single inpatient facility. And so it's not very large. It was maybe, I think, a 20-bed type hospital. And essentially we would screen all the patients coming in and see who of these patients had a stroke diagnoses and were coming in for that reason. Actually, a large part too of our criteria was that we were only working with people who had a first-time stroke that was resulted in hemiplegia. So actually the looking for first-time stroke survivors did exclude a lot of people, because a lot of people, it was their second or maybe third stroke that they had. The process, though, it was really nice that we worked closely with our physicians they would sometimes too, if maybe we missed somebody, or they would just say, hey, this person we think would be really great for this study. And so our clinical coordinator, Sarah Golis, pictured next to me, she's phenomenal. She did an excellent job recruiting, and we were able to recruit our 42 participants in a span of about 9 months. We felt really good about that. We had a little bit longer of an expected time criteria, but partnering with our administrators to get us that access to review charts made the process so much easier too. And that close relationship with the physicians was really nice. And then in terms of who was eligible, our eligibility criteria was fairly broad. They could have any range of motor deficit as long as they could feel the vibration on their non-affected side and had some movement there to be able to perform the exercises. That's what they needed. But for their more affected side, we had participants who had practically a 0 Fugel-Meyer score, like they couldn't move it. They could have no sensation on that side whatsoever, and they could still participate. We had, for most of our cohort, we did have a number of people who were higher functioning, so they maybe only had mild motor deficits or mild sensory deficits, or even like most of our people did have intact sensation. But even for people with deficits, they were still able to feel that vibration on their less affected side, and so they could participate. And then the other part that we didn't mention, people needed to have at least, or we gave them a Montreal cognitive assessment to look at cognitive function. We excluded anyone with severe cognitive deficits. So we did include people with mild or moderate cognitive deficits. I would say a majority of our group were either normal cognition or mildly impaired for cognition. And people who were mildly impaired for cognition still did really well with the system, which was nice to see too.
That's really cool. We're actually at the end of our time, but this has been just actually a really wonderful discussion and kind of a point to an enabling technology, basically, that could be translated worldwide. And I know that on the call, there might be people from a variety of different countries. If Bob could and Kimberly could drop their emails in the chat, and please follow up with them directly if you want to collaborate, know more. They drop their papers in the chat, so you can kind of, I think these papers are open source so that anyone can get them. So you'd be able to pull the paper, find out more, and maybe begin to dialogue. And if they're coming to Nigeria, and maybe we can get them to come to, you know, Botswana, where I've been doing some work as well. I think this is a great, potentially interesting technology that could be, you know, used in pretty much anywhere. I think that's the end of our webinar. Again, thank you all for being there. I'm going to give you a few minutes to grab the emails from the chat. And then so you can communicate with the presenters directly if you're interested in knowing more or even collaborating with them in the future. Any last minute comments, Kim and Bob and Rochelle?
Kim, I just wanted to say, would you mind reposting that and sending it to everyone? Because right now you've only sent it to the host, so I don't think.
Oh, gotcha. Thank you so much. I'm happy to do that.
Any last minute thoughts, Bob?
Yes, thank you everyone for your interest in our work, and thank you, Michelle and Rochelle,
Oh, thank you so
this
much.
opportunity to spread word about our fun little project.
I'd love to talk more. I had some questions myself, but we didn't have time. I was really interested in this idea of whether people, you know, like the idea that those with more severe, if you, because I'm interested in the intersection of motor and cog. So kind of wanting to, you know, did you look at your data that way? That would be quite interesting. And then I wanted to comment on the fact that the drift downward in kind of movement as you cued over time, it seemed like people got cued and then, you know, they worked a little, even though they were above the non-cue behavior, it still felt like they were losing interest, like you said, Kimberly. And I was like, I wonder how, if over time, if you can get a sense of who lost interest and who didn't. Those are some of the questions that came to mind as you showed that data set. Or not necessarily totally lose interest because they still exercised more, but what was kind of driving that loss of interest?
Definitely. Then that's something that we're still running some analyses on, is to look at differences in cue response based off of functional level or cognition. And I definitely agree. I think there was one person I know for sure they were moderately compared. So they were a person on that graph that you just saw, their pre-cue to post-cue is pretty much equal. And so I think it's an interesting idea of like at what point you know, what types of patient populations would this be most beneficial for? But overall, for our cognitively impaired versus normal population, and just looking at their user experience, there weren't any significant differences. At one point in time, people who were more cognitively impaired actually rated themselves higher on competence compared to the normal population, which kind of makes sense. They're a little bit more confident, or maybe less aware of their own limitations. But overall, people rated the system fairly similar, which was nice to see.
You said you did the MoCA. What was your cutoff point?
Anything less, I think less than or equal to 9.
Okay.
So most people, though, I think I'd have to look back at in the paper, it'll give the the average and some of the metrics, but I think people were mostly around like the 25 to 20 kind of mark for mildly impaired.
Yeah, so pretty mild.
Mm-hmm.
This is great, guys. Thank you. We're just so to respect people's time, we'll we'll release the seminar. Thanks again for coming on board and participating. And Bob, we still have to follow up on some of the things we talked about,
Yeah, Michelle, we do. Yeah.
Yeah, I'm really glad you were able to actually do this presentation, and hopefully more collaborations come out of it. I hope it will. I think working on something with you and with our collaborators in Botswana might be actually a reasonable thing.
Sounds great, Michelle. Let's explore it.
All right, take care, guys.
Everyone.
Thank you, everybody.
Thank you.
Everyone, have a wonderful day. We'll go ahead and end the seminar. Rochelle, do you?
I'm gonna stop. Okay.
That was